University College London Hospitals presents Techniques and Outcomes of Salvage Robot-assisted Radical Prostatectomy. Salvage radical prostatectomy distinguishes itself from upfront radical prostatectomy in the primary setting because of tough tissues and difficult planes. In open procedures, the dissection is often performed blindly and with hopeful anastomosis. In atrophic glands, salvage prostatectomy is often deemed not feasible. These hazards are translated into unfavorable outcomes. Robot-assisted salvage prostatectomy offers the advantage of better visibility and manipulation of the tissues and planes, with a better ability to perform a precise anastomosis and to resect tiny prostates. However, the outcomes of this technique are still underreported. A proper understanding of the primary treatment will determine the technique and the outcomes of salvage prostatectomy. It is most important to adapt your surgical technique to the primary treatment modality. After external beam radiotherapy or high-dose brachytherapy, the endopelvic fascia tends to be white, which makes it difficult to identify the lateral margins of the prostate. As the whole gland is irradiated, the prostate is stuck everywhere. Very careful posterior dissection is mandatory to avoid rectal injury. This is illustrated here. After brachytherapy, the fibrosis is mainly located at the apex, and the recurrence tends to be towards the prostatic base. This is translated into apical fibrosis and difficult dissection. To avoid damage to the urethra, the brachytherapy seeds are not placed in the midline. Hence, dissection should be done from the midline to lateral. Anatomical features after cryotherapy are similar. During DVC and apical dissection, brachytherapy seeds can sometimes be encountered. Following hormone treatment, the seminal vesicles tend to be very adhesive to the surrounding tissues. To ease the prostatectomy, it can be convenient to take the prostate and the seminal vesicles separately. In HIFU, the energy is focused near the prostatic midline. To safeguard the rectum is of prime importance, and dissection can be performed from lateral towards the midline, in which the rectum is dissected last and separated from the prostate. Irregularly shaped prostates with asymmetrical prostate lobes can be seen post nanoknife treatment, TURP, and photodynamic treatment. Very careful dissection and avoiding catheter traction can be useful. In order to lower the risk of rectal injury, an enema can be given to empty the rectal ampulla. Surgical exposure can be enhanced by the use of bladder and prostate stitches with an endoclosed device. Consequently, an additional robotic arm is available for traction. A Roberts catheter is placed which has an eye above and below the balloon to allow better drainage. Long-term absorbable sutures are used to avoid disruption of the anastomosis. We have developed an omentoplasty technique in which a tongue of omentum is dissected and brought down to the pelvis and wrapped around the anastomosis to enhance vascularity, and has also shown to improve continence outcomes. Whilst performing regis-sparing salvage radical prostatectomy, we use a peritoneal flap to give support to the anastomosis as well as to increase the vascularity in the area where the blood supply and the tissues may be friable. In the Department of University College London Hospitals, we performed a retrospective analysis of 203 patients from 2012 to 2022 with a minimum follow-up of 3 months. Primary treatment was HIFU in majority of the cases, followed by radiotherapy. Median follow-up was more than 2 years. Biochemical recurrence after salvage prostatectomy was seen in 21% patients, and positive margins were seen in 43%, of which less than 3 millimeters of positive margin was most common. At 2-year follow-up, 17% of patients were incontinent, which was defined as needing 2 or more pads in a day. Outcomes of salvage surgery were better after focal gland treatment as primary modality versus primary radiotherapy. Erectile dysfunction was present in the vast majority of patients. Only 8% developed perioperative low or high grade complications, and the mortality rate was 1%. In conclusion, it can be stated that salvage robotic-assisted radical prostatectomy can be regarded as feasible. Patients should be counseled that functional outcomes are inferior to those in the primary setting and that surgery can be part of multimodal treatment. Adjustments of surgical technique to the primary treatment is essential for obtaining optimal surgical outcomes.